there was some additional information about description. She was born in the north of Denmark, so the practice is in Copenhagen. She's a single mother. She has 3 children, and she grew up in the north of Denmark. She got pregnant at the age of 20, and she quit school. She got married to the father of her child, had 2 more children with him, but 4 years ago the couple decided to split up, so she divorced him. She went living with her mother and the 3 children. Father doesn't have any contact with the family anymore, and she decided to go studying again. So she studied for child nurser, and she graduated about a year ago. Couldn't find any a job in the north of Denmark. She had a job opportunity in Copenhagen, and she and the 3 children moved to Copenhagen. She works part-time in the kindergarten. She can't work full-time because she has the 3 children to take care of. Her income is quite low, 1,200 euros, and she has quite a limited social network because all her family and friends are living in the north of Denmark. She knows her colleagues at work, but doesn't have really much free time to socialize outside of work. She did have asthma diagnosed in her childhood and started chronic therapy, and she continued that until her first pregnancy when she was 20. When she became pregnant, she wanted to stop the medication because she was scared for the consequences for the baby, but also because she didn't really have much problems. So she didn't restart her chronic treatment, and she didn't have any problems until the divorce, and when she moved in with her mother, but she thought it might have been something to do with the fact that in her mother's house the house was quite crowded with the children and the mother. It was dusty, it was an old house, so she thought maybe it has to do with that. And there was chronic therapy suggested by her GP in the north of Denmark, but she stopped taking it when she moved to Copenhagen for a few reasons. First of all, because she thought, well, I'm not living in this dusty environment anymore, so it should be better. But also because medication is quite expensive, so she stopped taking them. And she said to herself, I don't need them anymore because it's also summer, and in summer it's better anyway. So that's the update on the patient. Next I will tell you something about, before we talk about inequity in healthcare, I think it's important to tell you about inequity in health. Yeah? And I'm going to show you a few figures, and they, except one, come from this very interesting report, if you're interested in this topic. The Marmot's group in the UK, they made a very interesting report, Fair Society, Healthy Lives, which is a follow-up of an earlier publication of Marmot, and it contains really useful information and numbers. But let me start by telling you the good news. This is the life expectancy in Belgium. It's fairly the same picture in all European countries. What you see is that life expectancy in the past centuries has risen enormously, and it still rises every year. Yeah. But there is a but, and this, from now on, these are UK numbers. This graph also shows life expectancy. The light green ones is life expectancy. The darker greens are the healthy life years. If you look at health expectancy, but when you look at the variation according to the deprivation rates of neighborhoods, and these are the most deprived neighborhoods in the UK, and those are the least deprived neighborhoods in the UK, what you see is that the life expectancy is much higher in the least deprived areas than in the deprived areas. And when you look at healthy life expectancy, you see the difference between the least and the highest is even bigger than the life expectancy. So people from the lower or from deprived areas not only live less longer, but they certainly live less longer in good health. And when you see that the dark line, that's the age of pension, if you see here that for people living in deprived areas, and even the less deprived, they don't even reach their age of pension in good health. It's only the rich ones and the wealthy ones who reach their pension in good health. Yeah. This graph shows the same thing, disability-free life expectancy, how long do people live without a disability, but for different regions in England. The only thing which is important to see is that you see a large difference between neighbourhoods, between regions in England, which also learns us or shows us that you can improve. There's margin for improvement. The lower ones can go up, so you can do something to make it better. Yeah. And then I put some variations in health down according to socioeconomic status of the individual. So it's not the socioeconomic status of the neighborhood, but of the individual. And if you look at birth rate, for example, what you see is that children whose mother is from a low socioeconomic status have much more risk on low birth weight when they give birth. They are born. Mothers have more postnatal depressions when they are coming from low socioeconomic backgrounds. When the children are reaching the age of 3, what you see is that there is a strong socioeconomic gradient in the fact whether parents read to their children, read them stories, and we know that reading stories to our children is very important for the development of knowledge and of language. And you see a strong gradient, and also you see a strong gradient in having a regular bedtime, and we know this is very important for children. What is important is that it's not only a problem of the lowest socioeconomic class, and that's sometimes what people talk about. They talk about the most poor people, the poorest people in society, and they have a problem. What you see is very clearly that there is a social gradient. Everyone in a certain social class is doing a bit less than the ones in the social class above. So also the ones in social status 4, which are the people with a degree of secondary school, so they went to school until 18. What you see is that they're doing less good than the ones within university, but they're doing better than the ones who have only low secondary school. So there's a strong social gradient, which already gives you some clues for interventions. You have to be very careful if you focus only on this group, because what we see now in graphs, in figures, is sometimes graphs who go like this. And that's because we put a lot of emphasis on the lowest groups, and their health is going up, meaning that this group is becoming the weakest group concerning health. So this is something we have to consider. Yeah. The child becomes older, the children become 11. What you see here is that social class is very important in the development of children. Children who are born in social classes, who are the higher professional classes, so that's the lawyers, doctors, their children, then more often go to preschool than children going from parents who are unemployed. And we know that going to preschool is very important, certainly for low socioeconomic classes. Mortality, the children become older, they become adults. Let's just look at this one. What you see is social class 1, the best ones, social class 4, the unskilled manual workers. What you see is that the higher the socioeconomic status, the lower mortality rates. And this is only for the people who are already employed, so the people with high jobs and people with low jobs. This is the graph for people who are not employed, but with high educational levels. And what you see is that even if you have a high educational level, if you're having a university degree but don't have a job, your health and your mortality rate will be higher, will be better than even the ones with a job but with the low income jobs. So having a higher degree is very important. Yeah. So what do we mean? You hear us talk a lot about health inequalities and health inequities. There is a difference between the two concepts. When we talk about health inequalities, we talk about differences in health status between people, between different population groups. If you see a difference between population groups in health, you can talk about health inequalities. What's important is that the population groups, health inequalities can also occur not only between people from a higher or low socioeconomic class, but also if you see differences, for example, between men and women, we can talk about health inequality. If you see that lung cancer prevalence is higher in men than in women, then that's an inequality, that's a difference, it's a health inequality. Yeah? For example, you can also have differences in mobility between elderly people and younger populations, or mortality rates between people from different social classes. They're all social inequalities. But sometimes differences between groups are purely or have a purely biological reason. If you see that sickle cell anemia is much more prevalent in black people than in white people, that's a social inequality. But it's not an inequity. It's something purely biological. It's a genetic difference between those two groups. So if you see a difference in sickle cell anemia between the blacks and the whites, that's an inequality, not an inequity. But if you see that women, black women, give birth to children with a lower birth weight than white women, that's an inequity. That's not only an inequality, there's an inequity. And the difference between inequality and inequity has to do with the fact that the reason, the underlying mechanism that makes or that results in this difference is not purely biological, but has to do with external environment and with conditions outside of control of the individual. It has to do with organization of healthcare. It has to do with redistribution of wealth and of income. And uneven distribution, that's not necessary. That's something a society shouldn't accept. And it's avoidable, and it's unjust and unfair, and therefore we speak about health inequity. Yeah.
I'm a little bit confused with that biological variation of free choice. For example, is smoking free choice?
That's a discussion. That's a discussion. Because you say people from low socioeconomic background, they smoke more. And there's a debate about it, whether that's an inequity or an inequality. Because it's a free choice. You can choose to smoke or not. But if you talk to people and you ask them, why are you smoking? And they tell you, I'm smoking because I don't have anything to live for in life. And it's the only thing I have left. And I have no income, and I'm a single mother, and so on and so on. There are some social mechanisms.
And in certain age groups, there is social pressure which is different in different groups of young people. So,
yeah. So inequalities in health become inequity in health when they are unfair and unjust, when they're preventable, avoidable, and not just. Yeah. Okay, let's go back to the story of our patients. You have some more background information now. What do you learn from this classes concerning the practice organization, and why do you think this patient, and you have to place yourself in the position of the patient, why didn't she come back to you? What could be changed in practice to make sure that she does come back? And why did she postpone her first visit? So she already has 3 weeks this cough and fever for a week, and it took her quite a bit to come. So maybe you can couple up again and think about possible reasons why this patient, this story, didn't show up.